kept constant by mobilizing the glycogen stores in the liver. During long fasts, gluconeogenesis is required to maintain blood glucose levels because glycogen stores are used up in about 24 to 48 hours. An individual with a fasting blood glucose level greater than 100 milligrams per deciliter is referred to as hyperglycemic. An individual with a fasting blood glucose level less than 50 milligrams per deciliter is referred to as hypoglycemic. Insulin is produced by the beta cells of the pancreatic islets of Langerhans. It promotes the entry of glucose into liver, muscle, and adipose tissue to be stored as glycogen and fat. It inhibits the release of glucose from the liver. Somatostatin is synthesized by delta cells of the pancreatic islets of Langerhans. It inhibits secretion of insulin, glucagon, and growth hormone, resulting in an increase in plasma glucose level. Growth hormone and adrenocorticotropic hormone, ACTH, are hormones secreted by the anterior pituitary that raise blood glucose levels. Cortisol is secreted by the adrenal glands. It stimulates glycogenolysis, lipolysis, and gluconeogenesis. Epinephrine is secreted by the medulla of the adrenal glands. It stimulates glycogenolysis and lipolysis. It inhibits secretion of insulin. Physical or emotional stress causes increased secretion of epinephrine and an immediate increase in blood glucose levels. Glucagon is secreted by the alpha cells of the pancreatic islets of Langerhans. It increases blood glucose by stimulating glycogenolysis and gluconeogenesis. Thyroxine is secreted by the thyroid gland. It stimulates glycogenolysis and gluconeogenesis. It increases glucose absorption from the intestines. Glucose is filtered by the glomeruli, reabsorbed by the tubules, and normally not present in urine. If the blood glucose level is elevated, glucose appears in the urine, a condition known as glucosuria. An individual's renal threshold for glucose varies between 160 and 180 milligrams per deciliter. When blood glucose reaches this level or exceeds it, the renal tubular transport mechanism becomes saturated, which causes glucose to be excreted into the urine. Type 1 diabetes mellitus is characterized by insulinopenia, a deficiency of insulin. Individuals require treatment with insulin to sustain life. Most individuals exhibit it as an autoimmune disorder where beta cells of the islets of Langerhans are destroyed by the body. Peak incidence is in childhood and adolescence, but it may occur at any age. Primary symptoms include polyuria, polydipsia, and weight loss. Ketosis-prone can produce excess ketones, resulting in diabetic ketoacidosis. Type 2 diabetes mellitus involves a defect in insulin secretion and cellular resistance to insulin. Individuals are not dependent on treatment with insulin. Individuals generally respond to dietary intervention and oral hypoglycemic agents, but some may require insulin therapy. It is associated with obesity and sedentary lifestyle. Symptoms include polyuria, polydipsia, and weight loss. Although associated with individuals over the age of 40, type 2 diabetes mellitus is becoming a significant problem in children and adolescents. Non-ketosis prone. Without exogenous insulin or oral hypoglycemic medication, these individuals will have an elevated glucose but will not go into diabetic ketoacidosis. Gestational diabetes mellitus, GDM, is the onset of diabetes mellitus during pregnancy. After childbirth, the individual generally returns to normal metabolism. However, there is an increased chance that type 2 diabetes mellitus may develop later in life. Glycogen storage diseases, of which there are 10 types, are inherited diseases involving the deficiency of particular enzymes. These deficiencies cause defects in the normal metabolism of glycogen. Von Gierke type 1 glucose 6-phosphatase deficiency. Pompe type 2 alpha-1,1,4 glucosidase deficiency. Cori type 3 amylo-1,6 glucosidase deficiency. Galactosemia is characterized by a deficiency or absence of galactokinase, galactose 1-phosphate uridyl transferase, or uridyl diphosphate glucose 4 epimerase. The enzyme defect prevents metabolism of galactose. Galactose is found in milk as a component of lactose, with galactosemia generally identified in infants. Most commonly, galactose 1-phosphate uridyl transferase is deficient, which leads to excessive galactose in blood and excretion in urine. Normal fasting plasma glucose, FPG, is less than 100 milligrams per deciliter. Impaired fasting glucose, IFG, is defined as a fasting plasma glucose level that ranges between 100 and 125 milligrams per deciliter. Provisional diagnosis of diabetes mellitus is made when FPG is 126 milligram deciliter. the diagnosis must be confirmed by one of the three methods described in the following outline section. A plasma glucose analysis that yields any one of the following results is diagnostic for the presence of diabetes mellitus, provided that unequivocal hyperglycemia is apparent. If unequivocal hyperglycemia is not apparent, the glucose result must be confirmed by repeat analysis on a subsequent day using any one of the following three methods. However, the American Diabetes Association does not recommend the oral glucose tolerance test, OGTT, for routine clinical use. An individual expressing physical symptoms and a casual plasma glucose level of greater than 200 mg per deciliters, fasting plasma glucose level that is greater than 126 mg per deciliters, fasting defined as no caloric intake for minimum of 8 hours, plasma glucose level of 200 mg per deciliter at 2-hour point of an OGTT as described by the World Health Organization, WHO. A woman at high risk for GDM should have an initial screening early in the pregnancy. If she is not found to have GDM during the initial screening, the woman should be retested at 24 to 28 weeks of gestation. For women of average risk, testing should be performed at 24 to 28 weeks of gestation. For GDM, fasting plasma glucose 126 mg per deciliters, or a casual plasma glucose 200 mg per deciliter, is diagnostic of diabetes mellitus. If unequivocal hyperglycemia is not apparent, retesting must be performed on a subsequent day. When using the two-step approach, an initial screening is performed using a 50 gym oral glucose load, time of day or time of last meal not relevant. Plasma is tested at 1 hour. This is a glucose challenge test, GCT. If the test value exceeds the glucose threshold value greater than 140 mg per deciliter, an OGTT is performed. Some experts recommend using a glucose threshold value of greater than 130 mg. Gestational diabetes mellitus may be diagnosed using an OGTT with oral ingestion of 100 grams of glucose. The glucose results must meet or exceed 2 or more of the following criteria: a fasting plasma glucose greater than 95 mg per deciliter, a 1-hour plasma glucose greater than 180 mg, a 2-hour plasma glucose greater than 155 mg, or a 3-hour plasma glucose greater than 140 mg. Alternatively, a 75 g glucose load may be used and glucose measured through the 2-hour period. Oral glucose tolerance test based on the criteria published by the World Health Organization, WHO. Note: American Diabetes Association does not recommend the OGTT for routine clinical use. Timed measurements of plasma glucose before and after ingesting a specific amount of glucose. Patient preparation: unrestricted carbohydrate-rich diet for 3 days before the test with physical activity. Restrict medication on the test day. 12-hour fast required. No smoking. Adult patient ingests 75 grams of glucose in 300 to 400 milliliters of water, and children 1.75 grams per kilogram up to 75 grams of glucose. For assessment of GDM, 50 grams, 75 grams, or 100 grams of glucose may be used. Plasma glucose specimen is collected fasting at 10 minutes before glucose load and at 120 minutes after ingestion of glucose. Urine glucose may be measured. Interpretation of OGTT results is based on the criteria published by the WHO. Impaired fasting glucose IFG is diagnosed when fasting plasma glucose ranges between 110 and 125 mg per deciliters. The following two criteria must be met for diagnosis of impaired glucose tolerance, IGT. Fasting plasma glucose level must be less than 126 mg deciliters, and the 2-hour plasma glucose level of the OGTT must fall between 140 and 199 mg per deciliter. Diabetes mellitus is diagnosed when the fasting plasma glucose level is greater than 126 mg per deciliter, or the 2-hour glucose is greater than 200 mg.